Hi, everybody, and welcome. My name is Stephanie Doback, and I'm the Executive Coordinator for the DNS DPG. Today, we're going to talk about the dietitian's role in nutrition support discussions at end of life. You may have heard of past legal cases involving feeding tubes. So they were all in the media back in the day. The Karen and Quinlan case, Nancy Cruzan, Terry Schiavo. These were all women in their young to mid-20s who had devastating accidents, leaving them in permanently unconscious states. Their families were left making decisions on whether or not to continue artificial nutrition and hydration. More than likely, you probably come across difficult cases in your own practice regarding nutrition support. Patients suffering from strokes or cancer or dementia. Some of these cases are black and white and pretty easy to navigate, and others are more complicated. So how should we as dietitians navigate these discussions? Well, we have two options. We can, one, punt them to the primary team, so leave it up to them to navigate the discussions alone. Or two, we can lead the nutrition discussions. From my own experience, I will say that this latter option may mean inviting yourself to the discussion. So if you're waiting for a physician invite, you might not ever get one. So just go ahead and include yourself. And you want to make sure that beforehand, you know what you're talking about, have rapport with the primary team, and I recommend you discuss the case ahead of time as a team so that you can all be on the same page. Again, from my experience, the primary team is typically appreciative of the dietitian's experience as a nutrition support expert and with their ability to answer nutrition-specific questions. So our goal today is to get dietitians more comfortable with leading the nutrition component of end-of-life conversations. First, we'll start with building your knowledge base about nutrition support at end of life by reviewing 5 common myths and the facts that debunk them. Then we'll discuss ways to interact with the medical team, patients, and family. Of note, from here on out, I'll refer to artificial nutrition and hydration as A and H. All right, let's get started. Myth number 1, a PEG tube will help patients with dementia not aspirate or acquire pressure ulcers. Because a PEG bypasses the mouth, you may conclude that patients won't aspirate if they have a PEG. And if the PEG gives them adequate nutrition, you may think that pressure ulcer risk may be low. Well, the fact is that PEGs have been shown to provide greater risk than benefit in this population. Studies looking at patients with dementia and PEG tubes show no improvement in survival time, mortality risk, quality of life, nutrition parameters, physical functioning, pressure ulcer, prevention of aspiration pneumonia, and overall comfort. In fact, PEG tubes in these patients puts them at increased risk for tube occlusion, now that they have a tube, leakage around the PEG site infection, GI complications, so the more that goes in, the more that comes out, use of restraints, and pressure ulcers. These patients are typically confused and they might pick at their PEG tube, so they might need physical or chemical restraints. Now they're sitting in their chair, more is going in, more is coming out, they have more moisture down there, and their skin is more likely to break down. Back to aspiration risk, even though we're bypassing the mouth for food, these patients might also aspirate on their own secretions. And myth number 2, intravenous hydration is harmless during advanced cancer. The fact is, IV fluids are associated with risk and a negative impact on symptoms, quality of life, and overall survival. So the studies looking at the patients with advanced cancer and giving them IV fluids or TPN show no improvement in dehydration symptoms, quality of life, or overall survival. In fact, we put them at increased risk for peripheral edema, ascites, and pleural effusions. Myth number 3, if I refuse A and H, I'm going to starve to death and suffer. The fact is that studies have shown that terminally ill patients do not suffer when A and H is withheld or withdrawn. They don't feel thirst or hunger. Keeping the patient's mouth moist by using ice chips, swabs, or lip balm provides the most comfort. The body is a beautiful thing and has systems in place to prepare itself for death. So when you go into that starvation mode, obviously you produce ketones, and ketone production is associated with somnolence and euphoria. The body also has this endogenous opioid or endorphin production, which is shown to decrease pain. If you're not taking anything into the stomach, you have reduced gastric stimulation, which is associated with decreased hunger. And towards the end of life, you had decreased hypothalamus function, which is associated with decreased hunger as well. So in essence, patients do not typically suffer from feeling starvation or extreme thirst at end of life. Myth number 4, ANH will allow patients to live longer and spend more quality time with their loved ones. The fact is that TPN, to-feed IV fluids require lines and wires and pumps, and sometimes physical and chemical restraints or a specialized healthcare setting. This can create physical barriers between the patient and family. It can also take away from the closeness between patients and families. So if they're trying to have an intimate conversation and alarms go off. The patient might actually perceive themselves as sicker than they are if they're tethered to a pump or an IV pole. And it may require living facilities further from home if the patient and family are not comfortable with managing home nutrition support. So as you can see, some aspects of ANH may inhibit the ability to spend quality time with loved ones. All right, myth number 5, our final myth. ANH is undeniably a basic need, and withholding or withdrawing it is a form of euthanasia. The fact is that while ANH may be considered a basic need on a personal or religious level, it's considered a medical treatment by medical and nutritionist societies. Legally, patients and families have the right to refuse or withhold ANH without it being considered suicide or murder. If started, ANH can be withdrawn if the patient no longer wants it or if the risk outweigh the benefits. Healthcare providers are not obligated to offer ANH if they believe it will result in fetal care. Ultimately, we know that it's the underlying disease that will lead to death and not the withholding of ANH. Now let's start applying this to practice. The use of nutrition support therapy involves understanding the medical indication, including risk and benefits. Next, it involves applying these interventions in a moral, ethical, and legal construct that is satisfactory to patients, families, and caregivers. Let's discuss how to equip yourself for these conversations on a personal, interdisciplinary team, and patient and family level. So on the personal level, we want you to increase your knowledge base of appropriateness, the risk and benefits of ANH in different scenarios. So you know that TPN comes with a central line infection risk. PEG tubes require surgery, so you have to outweigh the benefits with those risks. Considering any social or financial or educational obstacles for that particular patient. Know the different nutrition options available. So would a speech and swallow evaluation be appropriate? Would hand feeding be a better option than tube feeding? You can also offer high-calorie supplements or a liberalized diet or culturally preferred foods to increase oral intake. Even a simple resizing of dentures may make a world of difference. We also want to understand the patient's medical and nutrition history. So their weight history, their swallowing function, what has worked for them in the past and what hasn't. We also want to be familiar with cultural and religious views on ANH at end of life. Well, obviously, we don't want to stereotype or oversimplify this. Some religions deem ANH a basic need, but just because the patient affiliates themselves with that certain religion doesn't mean they believe in that specific stance. And then we always want to keep the principles of medical ethics in the back of our mind. So autonomy, respect for the individual person. Beneficence means that we're always going to strive for the benefit of the patient. Non-maleficence, which means do no harm. And justice. At the interdisciplinary team level, you want to make yourself known as a readily available nutrition expert. Attend rounds, come ready to answer questions. Again, don't shy away from these end-of-life discussions and ask to be involved. Know the different team members and resources available to you. So consider the entire interdisciplinary team, not just the primary physician. So ask the nurse, the PT, OT, speech pathologist, any disease-specific physicians on the case. So maybe that patient came in and is followed primarily by the GI team, but they've had a past stroke, and what is neurology's input into their quality of life? Involving the case manager, and social worker, and pastoral care when it's appropriate. Then we want to work with a team to answer key questions before the family discussion, asking, what's the patient's capacity or competency or developmental level? Is there an advanced directive or power of attorney on file? What's the best we can hope for in terms of prognosis and function? What are the benefits versus burdens of available options? And what realistically can we expect for the trajectory of this illness? Again, it's helpful to be on the same page and enter the discussions united as a team. What if there's disagreement about the plan amongst the team? So you might think, why is this physician so optimistic about the patient's future? I've known this diagnosis to be associated with a poor prognosis. So the physician is the expert in that field, and they probably know the latest research and treatments and the impact on prognosis. Know that the physician isn't wanting the patient to suffer either. So give them the benefit of the doubt and try to understand their background. We also want to discuss the plan of care as a team, and you want to keep your nutrition recommendations in line with the overall plan and goals. The goals of care and treatment priorities may change periodically, often with advancing disease. So if the patient has exacerbation of symptoms and rehospitalization or evidence of disease progression, this may lead to a change of goals. We always want to have a goal. If the goal is reached, great, we make a new goal. If the goal can't be reached, that's okay, we make a new goal. Of course, you want to clearly document the nutrition plan and directly communicate with the dietitian and team handling the patient's next care level. So now you're ready to talk with the patient and family. I think it's helpful to review nonverbal communication methods. So always try to make eye contact, sit near the patient at eye level. If they're in the hospital bed and you're standing up, that can denote a level of superiority. Remove your lab coat. No, there's such thing as white coat syndrome, and people are petrified of that white coat. So make them feel comfortable, and they might actually view you as more relatable if you take off the coat. Provide uninterrupted time, so silence your phone and pager. If you're sitting at a table, expose your palms and avoid crossing your arms or legs so that you can appear more approachable, or lean forward to show engagement. Purposely turn away from the computer or medical file and always have your body positioned to facing the patient and family. Have tissues nearby to provide as needed. Know that these conversations are typically emotional, so always have tissues on hand. Provide adequate seating and space for the team members and the family members. Use facial expressions to appropriately respond to a patient's affect. So nodding or shaking your head, grinning if they're telling a story of their past that brings them joy, concerned frowning. And then if it's appropriate, offer a therapeutic hug or touch. Verbally, we want to use open-ended questions. We want to allow the patient and family to do the majority of the talking. So really, you're going to be practicing the art of listening. Avoid interrupting or completing sentences, and utilize tactful pauses to gather your thoughts. Don't feel the need to fill silence. So you might feel awkward and be quick to provide additional medical facts or say, but patients need time to absorb what you're saying and to contemplate it. Remember that saying nothing is doing something. And we want to always exhibit empathy, which I'll go over later, acknowledging the patient's feelings. We want to determine their level of understanding of their case. So only 15 to 25% of verbal information is actually retained. Especially after bad news is given, people can shut down. Or they might hold on to certain words or phrases that gives them glimpses of hope. Ensure what is said by the medical team is heard. We first ask instead of just starting to explain, as this will determine our response. So saying something like, as of today, what is your understanding of your illness and the decisions to be made? Or what have your doctors told you about your illness? Again, we want to understand their personal, cultural, and religious values and goals. The patient's goals are one of the most important aspects in developing the plan. And goals can be anything from quality of life, avoidance of pain, having the ability to still do the hobbies they love, Some patients want to live as long as possible, no matter the quality of life. Some people hope for a cure or a miracle. And the others have more time-related goals, such as attending a wedding or seeing a grandbaby be born. Then you can discuss the nutrition picture, again, using these open-ended questions. So saying something like, hearing that life is limited, tell me what is most important to you at this point. Or what worries you the most? Or tell me your philosophy on A and H. Now, and then you can follow up with saying, based on your goals, these are the options, or this might be something that we pursue based on what is important to you. Phrases to use, we want to be direct, but also empathetic. So simply just providing 1 to 2 liners, not hedging. Hedging is beating around the bush. It aims to be polite and soften the blow, but it can be really confusing to patients. So instead of saying something like, there might be some risk involved, instead of saying, there's some risk involved. Instead of saying, I feel we should discuss long-term goals, instead of saying, it's time we discuss long-term goals. So if you want to address any misconceptions that the patient or family might have, you want to usually provide a warning shot. So saying something like, I'm afraid I have some difficult news to share with you. So that way they're prepared to hear it. Using I wish statements can simultaneously express empathy and the limits of their treatment. So saying like, I too wish that this disease will be cured, but if we can't make that happen, what are other shorter term goals that we might work toward? Using the terms hope or worry is helpful as well. So saying like, I also hope that you can get stronger, but I'm worried that your inability to tolerate the tube feeding is interfering with your ability to get stronger. And then addressing miracles. So saying like, we are all on board for hoping for a miracle to happen, but we need to plan in case it does not. If there's a conflict, we need to sit back and ask ourselves, why might this caring family be making a decision we think is unreasonable? And trying to work through that and any sort of barriers they may have. So you can verbalize empathy by using the mnemonic NURSE. And in that, the N stands for name. So we want to name the emotion. It sounds like you're concerned about the tube feeding side effects. U is for understand. So we want to seek understanding by paraphrasing what they said. If I understand what you're saying, you're scared your mother will starve to death. R is for respect. So accepting their perspective or position without judgment. It also helps to offer praise. I'm impressed with how well you're handling the treatments. S is for support. So validating their feelings and assuring them that you're there for them. You could say, I'll be available for you. And E is for explore. It's another way to find out additional information by asking questions like, it would help me to know more about your discussions with your husband prior to his illness. Some helpful phrases to use. Again, there's therapeutic silence. I can see that this is very upsetting. You seem overwhelmed by this news. And then just be quiet and let them contemplate what they're feeling and be the next ones to open up the conversation. Addressing anger, you might say, anyone in your shoes would be upset. And then if you've been having this conversation for over an hour, everybody's emotionally exhausted, you still haven't come to a conclusion, you can say something like, we've just had a very difficult conversation and you and your family have a lot to think about. Let's stop now and let you absorb what we've discussed. I'll come back tomorrow to get your thoughts and help you come up with a plan. Some phrases that we want to avoid because they're often not helpful are, in the event your heart would stop, do you want us to do everything possible? We're always going to do everything possible, but that may mean focusing on their comfort. The phrase, do you want us to continue aggressive care? I know we usually say aggressive care, but the term aggressive has an angry or forceful connotation, so we want to avoid it as much as possible. Saying withdrawing care. We never withdraw care. We're going to care for that patient till their last breath. We withdraw treatment, so we withdraw artificial nutrition and hydration. And the last thing, there's nothing more we could do. There's always something we could do, again, to provide comfort. So you might instead saying something like, there are no other treatment options that would provide benefit. I think the most beneficial thing to do right now is to focus on your comfort. So in summary, end-of-life discussions are not a one-size-fits-all. They're very patient-specific. Number two, there are many myths surrounding A&H at end of life, but you, as the nutrition expert, now know all the facts. And last but not least, dietitians are a very valuable asset to end-of-life discussions. Thanks for joining us today. If you have any questions, put them in the comment section below. Thanks and see you later.